Yeah, good afternoon, everyone. Thank you for this opportunity. I'll be talking about minimally invasive glaucoma surgery and its emerging role in our current scenario in glaucoma management. We are all aware of this. It's the leading cause of irreversible blindness in the country. Most of our patients are undiagnosed, and even those who are diagnosed, most of them remain untreated or poorly treated. Right now, in our scenario, majority of us we practice glaucoma, where majority of our patients are on medications and probably laser therapy wherever it's available. And once the glaucoma progresses to a severe or an advanced stage, is where we do a surgical management, mostly trabeculectomy. When that fails, tube implants, and when everything fails in an absolute glaucoma stage, is where we usually do a cyclodestructive procedure. We all are aware of these problems with medical management, where compliance is probably the biggest issue with our glaucoma management right now, where almost 60% of our patients don't adhere to their prescribed regimen. And when the patient is on multiple medications, this problem is much more. Ocular surface disorders, systemic side effects, poor quality of life with patients putting on multiple drops daily and dependence on the other family members, and fluctuations, the diurnal variation in the intraocular pressure. Whereas we know the benefits of surgical management, we have a more stable IOP, lesser visual field loss, lesser adherence and compliance issues, lesser ocular surface disorders, and much better quality of life. But right now, before the advent of MIGS, in mild and moderate cases, we did not have any surgical option, where most of our trabs and tubes were done in severe and advanced cases, because the risk of trabs and tubes outweighs the benefits in mild and moderate glaucoma. So this huge gap between our medicated patients and patients landing up with trabeculectomy can be safely and efficaciously filled with MIGS. What is MIGS? MIGS is minimally invasive glaucoma surgery. It's applied to a wide variety of implants, devices, and techniques that lower the intraocular pressure with less surgical risk. That's the main important point here. Than as compared to a trab or a tube surgery. So where do we do it? We do it in mild, moderate glaucoma, especially those patients who are undergoing a cataract surgery. We can combine this procedure. It's a 5-minute procedure where we can do it, especially in open angle glaucoma, pseudo-exfoliation, pigment dispersion syndrome, patients on multiple medications who are allergic to medications, contraindicated, non-compliant patients, and those patients who are keen on getting a glaucoma surgery. Why mild and moderate glaucomas only? Because the aqueous drainage is happening through the natural pathways, and the intraocular pressure is limited to the physiological levels only, where we maximum can get around 25-30% reduction in most cases. And in advanced and long-standing glaucomas, the collector channels in the Schlem's canal are known to collapse, so they might not work in advanced cases, this surgery. Contraindications, like we discussed, advanced glaucomas, advanced field loss, angle closure with extensive pass, secondary glaucomas, especially neovascular and uveitic glaucomas, extremely high IOPs is where we preferably do a trab. Glaucomas related to increased episcleral venous pressure. Some people are trying it in angle recession and pediatric glaucomas. There are some special indications where we can do it in post-filtration surgery as well, where the IOP reduction required is not very high, because conjunctival scarring is not relevant here. Thin scleras, staphylomas, where we can't touch the sclera, we can't do a filtration surgery. This has its special indication. Congenital and developmental glaucoma, we are already doing goniotomies, so this is something similar to that. And angle closures, where the angles open up after cataract surgery. Right now in India, we are mostly having a few of MIGS procedures where we can do an implant, which iStent and iStent injects are the only implants available now. We can do a trabectome, again the cost is very high, KDB, Cahook's dual blade, GAT or suture GAT, and bang surgery. I'll skip the case. This is the iStent Gen 1. It's one of the smallest implants to be, one of the smallest medical devices to be implanted in the human body. It's made up of titanium, which is heparin coated, and it goes in the trabecular meshwork to drain the aqueous through the natural pathways. This is how the injector looks like, and this is how we implant it in. We target the trabecular meshwork, and the button that is there on the injector, we just press that, tap the implant to see if it is in position. It is done with direct gonioscopic view under very high magnification. A little bit of blood regurgitating is a very good sign that you are in the right plane. Confirm the position, and you are done. This is how it looks intraoperatively. We usually put it in the inferior and the infero-nasal angles. Again, on slit lamp also, sometimes you'll be able to see it. This is on gonioscopy view on the slit lamp. Don't want to discuss this. Then comes the iStent Inject, or the generation 2, which has got 2 implants in the same injector. That's how the injector looks like. And this is how you implant the inject. The sleeve is first retracted, and you go perpendicular to the trabecular meshwork. The trocar is inserted into the trabecular meshwork perpendicularly. Create a small dimple on the trabecular meshwork. That's the dimple. And you press the black button. And you come back out slowly. And you go 2 clock hours inferiorly and repeat the same steps. Then there is KDB, where you excise the trabecular meshwork. And a modification, an Indian modification of that, is bent angle needle goniectomy, or bang surgery, where you take a 26 gauge needle and you excise the trabecular meshwork. Around 100 to 120 degrees of trabecular meshwork is excised.
Thank you, Dr. Amit. Please wind up.
I'll just conclude. So MIGS is not an alternative to filtration surgery, and it should be, there's a huge population of mild to moderate glaucomas where we can use this to stop the progression into severe and advanced stage. And for the ophthalmologist, MIGS can do for glaucoma what anti-VEGFs have done for retina. And for the young glaucomologist, this gives us a level playing field because it's new for everyone. And MIGS has created a paradigm shift in the management of glaucoma worldwide, and it's high time that we practice it in India. So it's a versatile surgery. We have done it for a 10-year-old and a 92-year-old patient as well. Thank you so much.
Thank you, Dr. Amit.
The iStent Gen 1, the MRP is around 69,000, and the iStent Gen 2 is around 1.5 lakhs, the MRP. The Gen 2 has got 2 implants in it, where, like I showed, we implant both the implants in a single patient, whereas the Gen 1 has got a single implant. So that's the difference, main difference. The IOP reduction is better with Gen 2. That's what both of them are available in India. It's not made in India. It's from a US based company called Glaucos.
I think there have been a lot of discussion last few years about MIGS, especially iStent. I request our chairperson to say, what has been your take on this? Do you think MIGS can be a part of glaucoma management in India?
I think over a period of time, this concept has been coming and getting a little more wider acceptance. We have just started seeing this happening in India as well. But I think if you look at the, why we need these stents basically is because you want a safer procedure. we have very effective ways of lowering intraocular pressure, but they have their own set of complications, and our endeavor is to lower the complication, and that's where actually these MIGS fit in. But their IOP lowering efficacy is definitely not as good as the traps or the tubes that we have been seeing. So I think there's always a little bit of a, like he highlighted, that there's a gap there where we are trying to fit in these implants. But if we look at our scenario, they're very expensive actually. I think the one MIGS surgery will cost you 100,000 rupees at least, whichever implant you put is in excess of that, plus you have the cost of the cataract surgery and the IOL implantation. The total package actually goes beyond to 1.5 lakhs or maybe more. And the IOP reduction you get in term is, sometimes it's actually questionable in that sense that because this is being done with the cataract surgery, so cataract surgery itself lowers IOP, and there's been a lot of debate in literature if you read whether this is because of the cataract surgery alone or how much is a part, with the MIGS, on this eye stent or eye stent inject is doing. So, but one thing is definitely there, that there is a IOP reduction because now there's enough data to suggest that cataract surgery lowers IOP, but on top of that lowering, there is some amount which is also due to, these implants. So now that data is kind of there. So to say that do these implants lower IOP on and above, over and above cataract surgery? Yes, they do lower. The next question would be, can we achieve same amount of that IOP reduction with other drugs? So we do, because we have no very effective drugs to achieve similar IOP lowering. So if you're using any of these MIGS, how much IOP lowering you get is somewhere around 20 to 30%. 30% is actually being very optimistic. 20%, 25 is probably more realistic. I would say 20% is more realistic.
In my 45 cases that I've done, sir, I've achieved around 30% reduction, and number of medications have decreased.
I'm speaking from the literature in general,
right, sir.
Because I'm not speaking my experience. I'm talking the literature in general. So I think that's the impression we get is somewhere between 20 and 30% you'll get that IOP lowering, which can be achieved by way of drugs also, and also doing SLT. SLT is actually very underutilized in terms. So what these, these techniques basically achieving is to kind of modify your trabecular mesh work area in some way so that you get more IOP reduction, and we have alternative methods. So put the story short, there is a place for the MIGS there, but this is still evolving, and the major drawback that we have now in our population, is basically the price. So if the price is too high for the amount of IOP that you
we have a good alternative for that. The bang surgery is a very good alternative where we are just using a 26 gauge needle, and for patients who can't afford an eye stent, definitely bang is a good procedure.
Definitely, I would say that I would recommend that. I think bang is the only procedure which I do most frequently actually rather than others. But but again, the bang experience is very less. The experience with the bang is less than 1 year. So we don't know what happens after 2 years, 3 years, 4 years.
Definitely.
We don't know. So you can't really recommend that as a routine procedure.
Right, sir.
So we had seen a 1 year follow-up of a bang surgery done in another eye with a phaco, and the other eye was done with a trabeculectomy, phacotrabeculectomy. The one eye is doing well, although the patient has some complaint, they have some irritation, some watering and like that. But the IOP is well controlled because that patient was sensitive on 2 medications, allergic to that one. But the bang surgery alone has not done, he need another surgery, I can say within a year itself. So I think there is definitely some scope, but not in advanced glaucoma.
No, MIGS is not that something which is new. It has been there because one of the means probably if you analyze it that way, that why it is there for so many years and is still not becoming popular. Especially in Indian scenario, we have to consider the cost, which is a very big issue. But according to me, these things are also probably pushed by the companies. And there are various, means probably we all understand how do the company try to push these things and then try to make it more popular. Also, it is not because the learning curve is also there in this, because there are many cases where reported that sometimes these implants are lost. You don't know where has it gone. And then 1, 2, even sometimes even some of the literature says three implants. So I don't know, then why not all 24 clock hours, 12 clock hours put 12 implants? So it is not that, the picture is not that rosy as it appears. So there are limitations, and it has been there for so long, and none of the implants have really so far picked up. There are so many in this mixed category, there are so many surgeries, but none of them have really picked up.
Sir, I have got a question to the esteemed panel, sir. What do you recommend and what is your take about combining GSL? That's GSL along with your cataract surgery for the angle closure cases, sir.
I think if you're talking about the angle closure case, there are many factors actually what exactly you want to do in implants, but the short reply would be that I would prefer a cataract surgery alone in angle closure and see what happens with the IOP. Because if you do the cataract surgery and don't do any other glaucoma procedure, the chances are, I would say 80% the IOP is going to come down to a reasonable level from where you can control with the drugs, except in a very advanced case where you want to have cataract surgery as well as glaucoma surgery. So I think bank procedure or any of these MIGS in case of angle closure is actually a difference. So I have a lot of reservations for angle closure patients. Even when you are combining with cataract surgery, because that's the place where cataract surgery itself can significantly lower IOP, maybe 30 to 40%, 50% sometimes I would say. So there is very hard to assess actually whether your MIGS is actually doing any good or it's not doing any good. But for open angle glaucoma is a little different story, and that's where I would say these MIGS would have some role. And Bang, of course, is my favorite as of now because it's very cheap.
Yes.
For that reason, yes.
Pocket-friendly for us.
Yes.
Thanks.
Thank you, sir.